ladies and gentlemen, to this exciting session which we are going to have on general anesthesia and the advanced modes of anesthesia in the during this launch of our workstation out here. So let me introduce our panelists out on this session. Let me introduce Dr. Yatin Mehta, who's the chairman of Medanta Institute of Critical Care and Anesthesiology. He's a renowned name in this session out there. Let me introduce welcome Dr. Yatin Mehta to this session. Thank you for working to attend this session. Let me introduce Dr. Amit Shah, who's the director and consultant anesthesiologist in KCHRC, Goraj, Vadodara. Welcome, Dr. Amit Shah. Thank you for agreeing to attend to this session and being a part of this panel. Let me introduce Dr. Mahesh Vakamudi, who's professor and senior consultant anesthesiologist at SMRC, Chennai, who's renowned for his lung protective ventilation in the cardiac segment, of course. Welcome, Dr. Vakamudi. Let me introduce Dr. Ritesh Roy, who's Associate Clinical Director and HOD at Care Hospitals, Bhubaneswar. Welcome, sir. I thank you all for agreeing to attend to be a part of this panel discussion, and I hope for an interesting time ahead out here. Since the advent of anesthesia, this is the one segment which has made surgery possible. And of course, with time, critical surgeries have also been made possible with great strides taken during this anesthesia. Anesthesia is the part which gives the surgeon the time to work, especially when you are handling some critical cases. And technology, of course, has played an important part in this. So when people are asking for faster things, newer things, better things, there is always an emphasis which needs to be put on the safety when we are handling things. And of course, when we are handling a situation where life is at stake, I think anesthesias and anesthesiologists have a huge impact in this space out here. So let me begin by asking, when we are talking of new advances, would it be at the expense of safety just to have a new technology introduced? In an era when people are talking of optimal anesthesia and all, how does optimal anesthesia and safety in anesthesia go hand in hand, sir?
I think Hemraj, it is better if you direct the question to us.
Okay, sir. Yeah. Sir,
or you open it, whatever.
Yeah. Let me begin with you, sir. For comprehensive monitoring, we know that anesthesia has to be safe. To make it safe, for our overall comprehensive monitoring, what all parameters would you consider as necessary when you are doing a normal surgery or a critical surgery?
See, before I come to that specific question, let me address the first issue which you raised.
Yes, sir.
There is absolutely no question. The advancement or the new technology cannot come in at the expense of safety. Safety remains absolutely paramount, and then the other things can follow. All right, so patient safety has to be paramount in all patient care. Coming to your, what are the newer advances? Well, more and more people are using low flow anesthesia, but again, the same question has to be addressed, that low flow anesthesia, that means you're obviously using less gases and less volatile agents, cutting cost, whatever, not at the expense of safety of the patient. So it has to be absolutely foolproof. When you cut down your fresh gas flow, come down to low flow, or come down to metabolic flow, it has to be absolutely foolproof. I mean, that means your monitorings have to be completely without any fail, which I'm quite convinced yours is. So that means your inspired oxygen concentration, your EtCO2, and your inspired anesthetic, inspired and expired volatile agents have to be monitored continuously and absolutely accurately without any compromise. Second thing which is important in the present, besides the other monitoring, which you obviously you need to do, and I could see that your ventilatory parameters were quite advanced. You can see the flow volume loops. You can adjust your, you can have recruitment maneuvers, which were not there in the earlier other anesthesia machines. So this is a major advancement, because in the COVID times, you are getting patients post-COVID also who are coming for major surgeries. So you have to be able to give a more advanced ventilatory strategies. You must have that, and without distracting you too much from the other rest of the patient care. So once you set the major settings on your anesthesia machine or on the ventilator for that particular patient and for that particular surgery, then it has to take care of itself, and more giving you a warning when it is necessary. So that it becomes a second thing. Particularly, it becomes more relevant when you have long surgeries, like say cardiac surgery or neurosurgery or liver transplant surgery and so on. So it becomes very important. This was a lesser recognized field. I mean, we always talked about anesthesia, concentration, need CO2, but regarding lung protective ventilation, very little discussion was on. So I am glad you have brought it up. Thank you.
Thank you, sir. We'll be coming to that later. To that thing. Dr. Vakamudi, let me ask you your views on safety, and what would be the care taken for different patient conditions and different conditions like the patient segment and critical case segment. What would be your basic views on safety during those procedures?
Yeah, thank you very much, Emraj, for that introduction. Just in continuation with what Yatin sir is talking about. See, it's very first important point that we all need to understand is that it is not appropriate for you to disconnect the patient safety from your routine operating practices. You know, what are the practices that you're talking about in conduct of your clinical care? Patient safety has to be an integral part of it. You know, we cannot look at it as a wheel within a wheel kind of a system. You know, then it will be a different culture altogether. So culturally, patient safety has to be integrated completely into your clinical care processes. That's a very important fundamental in any healthcare delivery system. Coming to the anesthesiologists and perioperative care, and you know, when we talk about these kind of aspects, there is so much of literature that's published across. We know that you know, there are the it's a beautiful opportunities that there. Wonderful opportunities that they're inside the operating rooms or in the set. We have been talking about it for ages. Of course, right from the same time, the Anesthesia Safety Foundation, Patient Safety Foundation has been started with the Institute of Medicine's report, and then you know how important it is to talk about patient safety perioperatively. We have come a long way now, in my opinion. You know, because even in India, most of the organizations, I see this in. Even in Tier 2 towns and even Tier 3 towns, it is now extremely well oiled into the whole processes about patient safety checklists in the perioperative care. That's something which is very, very important and heartening to see. And it has been shown in the literature that this implementing the perioperative patient safety checklist has actually reduced the errors in many ways. The patient safety checklist actually can also be improvised. In the current setting that it is now available by the World Health Organization, it can be improvised to even actually to the current settings. Like for example, you don't find the perioperative checklist and the preoperative checklist precisely. You don't find a detailed anesthesia patient check being there. But you can actually go ahead and start implementing such kind of, you know, you can customize your perioperative checklist. The World Health Organization has given and then to improve it. One of the important advances that's actually coming up in the perioperative checklist, we all know whoever is actually implementing this, you know, compliance to the to this checklist is extremely sometimes could be poor because it's actually individualized. What is coming up very well in 2013-14 onwards in the Western world is what I have not seen in too many institutes in India is that what is called a remote video auditing. Where actually audit your patient safety checklist implementations, which I think should be started in this country, you know, somewhere down the line. You know, it's very important in my opinion. Where when you talk about remote video auditing. There is a third party who is uninterested in this, but their only job is to actually look at auditing the compliances, whether these checklists are being implemented and followed routinely in the perioperative care. Coming to your question about the patient's critical conditions and criticality of the patients and perioperative safety, yes, it does have an impact in terms of an extra equipment. Instead, if you take a cardiac surgery in place, we do see people running around. When we actually need, if you don't have an adequate plan on your operating room preparations, if you do not have actually a plan for your inductions, you can actually have crashes. You can actually, it's very common to see people running around to fetch equipments or equipments that come in are not in order. They're not switching on. All that is a part of a critical care patient planning, depending on what kind of patient. It has to be probably tailor-made for a given patient beyond a baseline or a bottom level of a checklist or safety processes that you have in operating room. That's very important. Yes, it has to be tailor-made to the criticality of the patient. We may have to probably start looking at planning. So one of the important, 4 or 5 important things in the perioperative safety checklist is basically, you talk about review and informed consents. That's where your review, in the review process, you talk about your planning for your patient, for a given setting of the patient. And there's something called a structured communications, debriefings, and then briefings, and the handoffs. These are important components when you talk about perioperative safety. If you look at the experiences, I'm sure all the senior colleagues will agree with me. Most of the errors happen when you talk about handoffs. There is no appropriate handoff incident in operating room. That, or in the post-operative care, you know that it can actually lead to an error. So follow these structured processes of putting your patient safety across. You can also actually customize your patient safety depending upon the criticality of the patients.
Very interesting, sir. Very interesting. In fact, that gives me an opening to introduce a care session insight at a later date, sir. That would be something which is to do with connectivity and data analytics, which would be available with all our machines. I'll certainly be coming to that for you very soon. It's a very interesting concept, sir. Would really love it. Taking that forward, I request this from Dr. Shah. From a workstation point of view, like before I start the machine, what would be the attributes which we would need in a workstation to be 100% sure that, look, I'm going to take a case and I'm sure that these things are okay. And what would I really love to have from my machine on a basic one? Kind of thing. Like this would be the basic things which we need from a robust, reliable, safe workstation.
I think you said all. You only said those attributes.
Okay, I'm sorry. I didn't want to take the
point is that is your USP. So you said all. So you need.
I need your views, sir.
So you need first of fail-safe mechanism. That is, I think, the most important consideration, as we already talked about safety on by Dr. Vakamudi and Dr. Yatin Mehta both spoke about safety. So fail-safe operation is something which is the first priority. If I'm starting a machine, I know that this should work. It should check perfectly that, okay, machine is perfectly working and it is not going to give me any blues on the way while I'm performing my anesthesia. So fail-safe is something which is, I think, is the first priority. Of course, reliability is the next thing where, if I decided to give 400 ml tidal volume with the low tidal volume which we are delivering, if it is delivering lesser than that or higher than that, then I'm not sure what I'm delivering. So the reliability is the second most virtue, which is, I would say, the most important. And third and very important thing is familiarity. These days, all operation theater may not have same anesthesia machine. You may have a different anesthesia machine. And if you go to that machine and if you have to deal with the screen again, and you don't know where things are placed, it becomes very, very difficult. So familiarity is also one of very important attribute which I see with the G machine, where every machine has a same screen has the same workplace ergonomics. So organization is same. So you don't have to search for anything. If there is a problem, if there is a complication, if there is some extra efforts are needed, you are sure where those things are and how you can deal with them. So familiarity, reliability, and fail-safe. All these three things are absolutely important virtue. Fail-safe among that is the best, most important.
Thank you so much, sir. Thank you so much. Thank you. Thank you. Thank you so much. Coming to you, Dr. Ritesh Roy, assuming COVID-19 is receding and the elective surgeries are back in swing again, what would have changed in our approach to patients with the post-COVID lung? Do we really see a difference in the kind of patients which we used to have earlier and the kind of patients which we are having post-COVID? And what are the changes in the approach which we need to look out for during these things?
Yeah, thanks, Hemraj, for a very pertinent, hot topic right now, the post-COVID ventilation scenario. Basically, if you see around 80% of the post-COVID are basically a mild asymptomatic patient. The rest 20% which are moderate with respiratory involvement, and another 5% which are severe. These are the patients which will cause problem to us when they come back for any elective procedures. Because usually what happens in these patients, you have, they might have pulmonary fibrosis, they might have interstitial lung disease, they might have a restrictive lung disease. So the concept of lung protective ventilation, which we have been trying to advocate, but still, to be very frank, I will tell you, it's not followed in India in many of the centers. The concept of this lung protective ventilation has to be learned and by each and every anesthetist, because each and every anesthetist is going to encounter these type of post-COVID patients. And we have to go for a concept of lung protective ventilation so that already the lungs are damaged. We don't want to damage that further reserve which that patient has by ventilating him in an improper way. And obviously, these patients, even in lung protective ventilation, if your patient has a interstitial lung disease on a repeat HRCT when he has come for elective surgery, obviously we will not go for those recruitment maneuvers. We have to be very careful about the amount of PEEP which we are going to use. So these are the differences. And right now, in this scenario, the COVID scenario, the lung protective ventilation has to be learned, and the way it has to be done, each and every anesthetist should know, so that we give better outcome to these 25% or 30% of the patient who have a severe respiratory involvement and they will come back for the elective surgery.
Thank you. That will lead me to the next set of questions based on lung protective ventilation. Before we begin there, can I have a small poll during that so to understand our viewers' impact on this? I mean, views on this. And let's take a small poll on this. So there will be a poll coming on your screen. The question is, what are the evolving concepts during anesthesia for better outcome, better oxygenation, and improving the lung compliance? It would be popping up in your screen. There's been a good response so far. I think nearly 80% of the people are claiming lung protective ventilation has a good impact, along with recruitment and driving pressures. So my next set of questions, nearly 80% of the people were in favor of lung protective, sir. Okay. Lung protective and lung recruitment, followed by driving pressures. So I have a next set of questions for you, sir. Lung protective strategies, which are an integral part of safe ventilation in OR. However, of late, it's been acknowledged and debated with various degrees of consensus. I need your view on the practice of this different lung protective strategies, sir. Because we
See,
believe
what
that's
Dr.
not just
Roy said was completely right. Awareness in India by the anesthesiologists regarding lung protective ventilation in the OR is very little. So I think we need to increase the awareness and we need to start implementing it, particularly for major surgeries particularly with compromised lung functions. Like best example at this point of time would be post-COVID lungs who come for major surgery because they've been waiting for a while. And as Dr. Roy rightly said, the lungs are maybe less compliant, more fibrotic, the diffusion capacity is affected. So these are the lungs which need to be protected. If you have very high airway pressures, you'll pop something in the lung. They're more likely to get pneumothoracis and pneumomediastinum. And oxygenation may be impaired, so that also you need to regulate your oxygen, inspired oxygen, again to regulate that. So, I mean, these patients do require lung protective ventilation. Also, ARDS network awareness is also very little among anesthesiologists who are only restricting themselves to the operating rooms. So you must realize now, particularly during COVID times, I think all of us have led the fight against COVID. So we all have been very actively involved in the COVID care in the intensive care unit. So our perioperative care should continue into the post-operative or post-procedure care. And I see no reason that what sort of ventilation you are going to exercise post-procedure or in the ICU, you should not do it in the operating room, particularly if you have major surgeries for long periods of time. I mean, why do we need to ventilate them at large tidal volumes with high pressures, hoping that electricity would be less and oxygenation would be better? I mean, I scream at my people all the time because they like to see 100% saturation on the screen. And I said 100% is not good. This is a misconception that it is safe. It is not. In fact, several studies have showed that mortality is higher if the saturation is 100%. I mean, it is better if it is 92 to 95%. Anyway, so lung protective ventilation must be, the awareness must be increased, and we should do that. I mean, that means your driving pressure should be on the screen, your plateau pressure should be displayed, your PEEP should be displayed and regulated according to how much tidal ventilation you are giving to the patient. And if you have monitoring of EtCO2 and obviously saturation, you can regulate it without doing too many blood gases also if you don't have an outline. So you should be able to do that. And I think we need to increase the awareness that you do not require large tidal volumes. You do not require zero PEEP. In fact, you do require PEEP. And wherever feasible, recruitment maneuvers may be very much doable, particularly if the anesthesia machine is smart enough for you to, I mean, just press a button and it gives follows the recruitment maneuver in different whatever format you have. So I think these must be, because atelectasis is not at all uncommon after major surgeries of thoracic and abdominal cavity surgeries. Even you look at the laparoscopic surgeries, they also have a significant atelectasis. So all that is preventable. These are the patients who are likely to have trouble post-operatively. And if you start your whole process of adequate ventilation without producing atelectasis, but maintaining oxygenation, I think that whole exercise should carry on post-operatively after the patient is out of the operating room.
Very true, sir. Very true. Let me take it forward to Dr. Vakamudi. The ICU concept of driving pressure and adequate minute ventilation, would they still be workable in the OR environment, sir? Because the concept of 12 centimeters or 15 centimeters and adequate minute ventilation to achieve a CO2 removal, would they be or should they be ideally followed in the OR environment?
Yeah, I mean, I think it's in continuation again with what Yatin sir is saying. I think, see, the first point that we all need to remember and understand is, if you're talking about protecting lungs, and that should start happening pre-induction. That should come as a goal right from there for the anesthesiologist. And that should come as a plan, because you have a potential problems intraoperatively that you can create, and you can't expect those problems to be taken care in the post-operatively and then start talking about protecting your lungs post-op. If you can actually take care of a lot of these things, pre-operatively, like for example, if you're looking at a pre-operatively lung protection strategist, you should start talking about which are the patients who are on high risk for this post-operative pulmonary complications. We call that very common ST disease. If you're looking at running a checklist, for example, you're looking at a surgery more than 2 hours, you have an ASA patient who's more than 2 status, you have patients who are, preoperatively hypoxemic for some reasons. You have patients who are BMIs of more than 40. There is a fixed calculation and a score for predicting the preoperative, the postoperative pulmonary complications. If you actually can start planning, suppose the anesthesiologist get in the habit of looking at high risk or catching them preoperatively, the high risk patients for postoperative pulmonary complications, then your plan to protect your ventilator lungs should start preoperatively and continue intraoperatively and then into the postoperatively as the different strategies and maneuvers that you actually apply. For example, we normally pre-oxygenate patients with 100% oxygen preoperatively. We all do that. That's a very important mandatory practice. And when you're doing it, if you start having an upper airway obstruction, that's the first time that you actually encounter a intraoperative collapse of the lung. That's a very important. So you should be, if you're looking at protecting the lungs and preventing atelectasis and lung collapses, you should ensure that your upper airway is actually very patent. And then you should make sure that's a very important. As an example, I'm saying how you actually should plan out. What are the stages in which you can actually have potential lung collapses and atelectasis. The second important point is that I would talk about intraoperatively. Yes, all this that we talk about postoperatively in your mechanical ventilation and then established ventilators that are actually built postoperatively to take care of the lung protection and in typical lung mechanics scenario should also be taken care, especially in the post-COVID scenario, because you will definitely be facing, all anesthesiologists will be facing, because you're going to live with COVID for a very long time. And then you would definitely have patients coming with difficult lungs preoperatively, and then you should start an aim of protecting these lungs intraoperatively, definitely. Apart from other subsets of patients in clinical cases, like, a major abdominal surgeries, major laparoscopic abdominal surgeries, a major thoracic surgeries, cardiac surgery, all of them, any surgery, even neurosurgeries, for example, if they're going, because the neurosurgery gets prolonged neurosurgery for more than 6 to 7 hours, sometimes you have postoperative pulmonary complications, definitely. So all these things are important for us to start talking about. Then your driving pressures. You should get into a habit of actually monitoring, as what Sir again is saying. An anesthesiologist should get into monitoring habit. See, we all make anesthesia records. We plot heart rates, we plot blood pressures, we plot pulmonary saturations, and now routinely, I'm very happy to see very often the people plotting the entitled carbon dioxide. So it's a great practice that's been with the very focused across a decade or more in this country. I'm seeing at least more than 60-70% of the anesthesia operating rooms and perioperative practices, you are charting the entitled carbon dioxide. It's a great practice. But I think you should also start practicing charting your peak air pressures, the plateau pressures, and also the compliance of the respiratory system. Because having said this, I know we have constraints across the country. We do not probably have a lot of anesthesia machines with ventilators as it is. In fact, some time ago, I was asking Ms. Viranyalu to see if you can actually get the data across, because you can even collaborate with other major companies and see what a percentage of operating rooms across this country has anesthesia machines with ventilators and without ventilators, and what kind of, surgeries do they normally handle. I'm sure we can send a survey questionnaires and at least know what stage. See, because you can't talk about lung protective ventilation and any of the strategies, you don't have mechanical ventilators at all in your anesthesia machines. So, but in those areas where you have those machines, or in operating rooms where you have machines and with mechanical ventilators available, at least you should start opting for those machines where there are the parameters are actually visible and available for you to monitor. So let's get into this practice of monitoring and charting your peak plateau pressures, your peak airway pressures, the plateau airway pressures, and the compliance of the respiratory system, which will come there. I mean, even if you have a peak pressure and you know the tidal volume, you know your respiratory compliance. All anesthesiologists should be able to calculate the compliance of the respiratory system given the peak pressures, both the static and dynamic compliances. If you know the peak and plateau pressures of the tidal volumes, you can actually know the compliance of the thing. The third important point always talk about when you talk about lung protective ventilation. A patient who started off with by and large normal, decent lungs preoperatively, intraoperatively over a period of time in about 45 minutes or 1 hour, you have an oxygen saturation from about 99 or something with 33% oxygen is dropping down to a saturations of 95 or 94, for example. The normal trend I see across is to actually increase the FiO2. I think that's something which we need to aggressively talk. Increasing FiO2, while it is mandatory, but it does not solve the problem. More 9 out of 10 times such drops in oxygen saturations in a previously normal baseline saturations often happens because of the because anesthesia itself is a very, very fertile condition for actually dropping FRC and producing perioperative collapse. The moment you have a patient who is coming and lying down on operating table, your FRC start dropping. And then you give anesthetics, it drops much more, and you give relaxants, it goes much more lower. So that's a fertile condition for you to have problems. So of course, the hemodynamics also make an impact on your postoperative pulmonary complications, and also the lung collapse. See, this is a strategy that you need to adapt in the multi-pronged nature. We need to look at multiple things. The fourth important point that we need to very, very be careful and be consciously we should avoid is using 100% oxygen at any given point of time, except for brief periods during your pre-inductions and pre-oxygenation times, and at least for the very, very brief time at the most at the peri-extubation times. Even at the extubation, I always suggest to people you don't need to really use 100% oxygen if you're not using the nitrous oxide. If you're actually using air oxygen, and then you're extubating a patient from a comfortable levels of good intraoperative hemodynamics, no major perioperative, and you've taken care of your peak pressures, plateau pressures, everything well, and you have full unproductive strategies in place, limiting your tidal volumes. Intraoperatively surgery which is lasting more than 1.5 hours, or a laparoscopic surgery with high intra-abdominal pressures that you actually recruited your lungs. Such patients, you should not actually look at extubating them on 100% oxygen. You should probably, because it's been shown across the literature in many studies that if you use more than a FiO2 of 0.8 in the extubation areas, you will definitely have sometimes a problem of a postoperative pulmonary collapse, especially if you have laparoscopic abdominal surgeries. Because the base in the laparoscopic base of the lungs do have collapse when you have a laparoscopic surgery. That's in the trend positions that you give normally. So these are important things. Yes, drying pressures are important, as all the parameters that you talked about for ventilatory characteristics in the postoperative period are as important in the intraoperative period as in the postoperative.
It's a very in-depth view. I mean, I knew a little bit of this, but point really well taken, sir. Dr. Shah, you have been taking classes for many people and all. In your opinion, what are the constraints for people not to be adopting this lung protective ventilation, which has been probably very well documented in most of the cases, so with so many papers and all? What's your view on why people don't really follow it so much, sir?
Well, there are two things. One is age-old technique of using default tidal volume of 500 ml for all the patients. I don't know why it is given as a default value in all the machines. All the machines have 500 ml as default value, and then they use it as default value as the tidal volume, which they feel that it is the correct tidal volume technique. Maybe earlier concept were of 10 ml per kg body weight, and average patient's weight was 50 kg, considering that 500 ml tidal volume was the default value, and that is what they use for the majority of ventilation in the majority of the operation theater for majority of the surgery. So their older consideration of 10 ml per kg body weight as an proper ventilation technique for the anesthesia is the one major hindrance in accepting this newer lung protective ventilation, which is found to be, I would say, more healthy, safe, and actually there is no problem with that. People feel that because we are giving less ventilation, patient's EtCO2 will rise. Earlier, probably we were not having EtCO2 monitors regularly, so we were actually worried about it. But now we have an EtCO2 monitor, and there is no point, and there is no, excuse me, you can always look at EtCO2 and find out whether you are giving adequate alveolar ventilation or not. So lower tidal volume, that understanding itself has not reached. That is the first important consideration which so that is what we do in majority of our such workshops, where we show them that it is not necessary to give tidal volume of 10 ml per kg body weight. You can go down. You should actually use the predicted body weight rather than the ideal body weight. And then 4 to 6 ml per kg body weight is sufficient for the adequate pulmonary ventilation. If you have actually EtCO2 going up, you can increase the minute ventilation. You don't need to increase tidal volume. You can increase the minute ventilation by increasing the respiratory rate so that your adequate CO2 clearance is there. Also, another important problem is that most of the people don't know what is plateau pressure, how to get plateau pressure. That is another major problem, right? They don't know that you need to give pause of 10% in the machine setting to get the plateau pressure, which gives you then the driving pressure. So concept of driving pressure is also majority unknown in the anesthesia field, where they don't know what is a driving pressure and what is the importance of driving pressure. Of late, with the various studies which has been published, we also come out with the open lung concept, where we need to open the alveoli, and if you are not adequately ventilating, if you are not giving adequate PEEP and intermittent recruitment maneuver, or as Dr. Vakamudi sir said, that you should start this lung protective ventilation right when you do pre-oxygenation. In fact, when you are doing pre-oxygenation, you give for a very brief period 100% oxygen. So you can add CPAP or a PEEP while applying the pre-oxygenation, so that will keep your lung alveoli open.
And collapse.
And when you start ventilation, you reduce your FiO2, continue your PEEP, and if you feel that your peak pressures are going up, if your plateau pressures are going up, if driving pressure is going above 30, then it is a time that you should apply the recruitment. Now, maybe a routine surgery for a peripheral surgery where you give general anesthesia for a very short period, you may not have done this type of procedures. But all other surgeries, which is a prolonged surgery, laparoscopic surgery, obesity patients, neuro patients, again a prolonged surgery, all other categories of surgery which falls into category of major surgeries, we should always give the recruitment maneuver, and then it should be immediately followed up by the PEEP. Suppose if you give recruitment maneuver and then if you don't start PEEP immediately, the collapsing segment will start collapsing again, and the atelectasis will start. In fact, we have developed a goat cadaver model where we are showing very, it is very convincing that as soon as you stop recruitment maneuver, the atelectasis starts. Unless you apply PEEP simultaneously, as soon as you stop the as soon as you do recruitment maneuver, then only atelectasis is prevented, and you can prevent the atelectasis for a longer period of time. So applying the recruitment maneuver immediately followed by PEEP is very important. Now, we are not convinced because we are not sure. Majority time saturation because of good FiO2 is on the higher side, and we are not worried about it. But if you have not done this maneuvers in this major surgeries which we described, probably you'll see patient on oxygen for a long period in the post-operative time. You need to give head up. You need to ask them to take deep breath. You need to take them to do exercise. Then only the saturation will remain up. Otherwise, you'll end up in giving oxygen. patient going for the ventilator may not be that large. So that is why a routine surgery, routine anesthesiologist feel that he has not encountered such patient in his career where patient had to go on ventilator for developing atelectasis. But definitely patients ICU stay will increase, patients recovery room stay will increase, and you need to give oxygen for a considerable period of time in the post-operative.
Very interesting insight, sir. In fact, that gives us still some space to work in the field, rather than just talking of what features we have. We know that these are the places where we can give some additional inputs there. We need a little bit of more work to be done with the machines, with the attending clinicians. Coming back to you, Dr. Mehta, and probably Dr. Roy also, since we have this lung protective strategies around here, would it be needed only for a certain specific range of people, or like a category of patients? Like, would it be routinely, normally applied in the same way for pediatrics and neonates also, or any age group? Like, for instance, like in the cardiac segment, there is one specific segment where a specific time when the lung is completely down for a certain period of time. So for these patients, would there be a specific need, like the specific way of applying this lung protective strategy, sir? Like, I know that for certain that.
Yeah.
Yes, sir. Carry on, sir.
In the older days, when we used to do with Boyle's machine, when the patient went on cardiopulmonary bypass, you used to disconnect the ventilator.
Yeah.
Okay.
Yeah.
And the lungs used to be completely collapsed. Nowadays, we realize that there is going to be significant atelectasis with the prolonged cardiopulmonary bypass, and there is no need to do this. Most of the modern anesthesia machines, and I'm sure your 760 case station also has that they have a mode of cardiopulmonary bypass. So you just put the anesthesia machine on that, and there is a low flow oxygen, and with the beep, so the lungs remain non-atelectic. So this is the one thing which I'm sure you have it. Also, this Dr. Vakamudi rightly said about the certain patients who are more likely to get into post-operative atelectasis and trouble because of that. These are morbidly obese patients, prolonged surgery, tendon bug positions in the operating rooms, patients who have pre-existent lung disease, structural lung disease, patients who are recovering from other diseases like COVID and so on, or patients with low lung compliance because of left heart failure, the cardiac function ejection fraction is low, and they will have congestion and certain degree of pulmonary hypertension. So these are the patients who can get into trouble. So you need to identify pre-operatively which are the patients who are going to require special care. And obviously, longer the surgery, more the problem can happen. So, if the surgery is for a short period, half an hour, 45 minutes, it really doesn't matter whether you do lung protective ventilation or not. But if it is for a longer period of time, particularly in these high-risk cases.
Sir, just one question, sir, Dr. Vakamudi. Like when we ventilate, we have the FiO2 and the map for oxygenation and the minute ventilation for CO2. Now, when we are controlling the tidal volume to say something like 6 ml or 7 ml per kg, the amount of carbon dioxide or the VCO2 which a patient gives off, that remaining constant, how much is the minute ventilation which we need to achieve to drive it off, sir? Like, on one hand, we are reducing the ventilation. We need to increase the minute ventilation by increasing the rate. But would there be a target for minute ventilation? Like in the ICU segment, I had seen some papers claiming that for a standard person, the ventilation would be targeted at something like 100 ml per minute per kg. Like this thing. So how much would be a target minute ventilation for a patient in the OR environment when we are doing lung protective ventilation or low volume ventilation?
See, the first important point that we need to remember is that, this is in continuation with what Dr. Shah is rightly saying. For some reason, we talked about this calculations of 12 breaths per minute in adults with 500 ml per kg and 6 liters per minute as a target minute ventilations and all that stuff. But I think it's predominantly at 6 to 8 liters, 6 to 8 ml per kg of a tidal volumes by and large with about 12 to 14 breaths per minute. If you are actually monitoring your entitled carbon dioxide, that most of the times, 90% of the times, in a given set conditions, if there are no other surgical indications that is impeding your ventilation or increasing your decreasing your respiratory compliance, and then or increasing the resistance to breathing or any of those conditions, then most of the time 6 to 8 ml and 12 to 14 breaths per minute, I think is by and large enough. If you're monitoring your entitled carbon dioxide and your entitled carbon dioxide is within the 35 to 40 millimeters. I don't think we need to be worried about that. It doesn't change even in local anesthesia. But these targets are standard, and these targets are actually meant to keep your entitled carbon dioxide between 35 to 40 by and large. If your entitled, the first sign of your inadequate minute ventilation could be your entitled going up. Then you have to run a series of checks, whether it's just not minute ventilation. There are so many other things that could probably be like the first thing that we all be trained to look at is if you're using a closed circuit, you have to ensure that your carbon dioxide absorbing systems are in place and they're completely in order. As an example, I'm saying, your HME filters and your peak aero pressure should be monitored if they're high. The lung compliances has to be checked. And your intra-abdominally, if you're doing it, for example, you see the entitled carbon dioxide going up if you're doing a thoracic surgery, and if you're using 6 to 8 ml per kg sometimes. The double lumen ventricular tubes, you may have to probably use a high tidal volumes. If there is a lung packing on the side of which we are using, or there's a compression on the dependent lung. All those things as surgically surgically mediated conditions. But by and large, if you're looking at the standard operating conditions in which you look at the tidal volumes and minute ventilation that are required, 6 to 8 ml per kg body weight with 12 to 14 breaths per minute is by and large enough if you're monitoring your entitled carbon dioxide.
Thank you, sir. Thank you. Thank you so much. We had quite a bit of discussion on the lung protective part. So let's move. Yes, sir.
I would like to definitely add and agree with Dr. Ritesh Roy that the lung protective ventilation should be part of all the ventilation, irrespective of the duration, surgery. It has to be there. There is no harm in doing it.
Yes, I fully agree, sir.
It should be there with all the ventilation. Whenever you do, it should be lung protective.
Very true. Very true. Driving pressures of 12 to 15, adequate PEEP, and target 6 to 8.
Hemorrhage, one important concept in continuation again with Dr. Shah for the benefit of the audience, I would probably say, is very important. That's something which they can actually remember for as soon as they enter the operating rooms for every day for the anesthesiologist. The concept is, as Dr. Shah already talked about, it's open the lung and keep it open. Is the tagline that they need to remember.
Yes.
Open the lung and keep it open. Open the lung is like, you actually do a recruitment maneuver and open the lung. And then, but as Dr. Shah rightly says, it is just going to collapse if you don't keep it open. So you need to add either the CPAP or a PEEP bit, depending upon the type of the patient's breathing conditions and the situations that are there. So all anesthesiologists should remember this intraoperatively. Of course, this is a great concept that's already built into the postoperative periods. Everybody talks about it. If you walk into ICU, everybody talks about it. But people does not talk about it so seriously and intraoperatively inside the operating room. So it's a culture that we need to get into. As Dr. Roy rightly said, every patient has to be looked upon as if there's a potential for a collapse. Whenever you talk about the general anesthetic, it is not, again, very importantly, I'll also say this, it's not just the general anesthetic. If the patient comes down and lie down on the operating table here for a little long periods of time for regional anesthesia, they can still have a postoperative lung collapse if there are the perfect conditions. Like, for example, if the BMIs are high, even if you don't get general anesthetic, if they lie down on operating table but of course, you need to take a calculated call on whether you need to put these patients on a CPAP on a spontaneously breathing patients. If their BMIs are high and the PPC, the incidence of PPC or risk score for postoperative pulmonary complications are high. But of course, that's a little bit of a different segment altogether, but it's important for us to remember this.
Hemraj, to add to it.
Very true, sir.
Mr. Hemraj, to add to it, for the viewers, the most important parameter in your lung protective ventilation The main parameter to watch is your driving pressure. If you are keeping your driving pressure within 15, you are not injuring the lung. And if you are seeing your plateau pressure going up, you don't have a fixed idea that I am not going to increase my PEEP. You increase your PEEP, bring your driving pressure within 15 centimeter of water. That is the pressure. If you control, the harm to the patient will be much less.
Much minimized. Just for discussion's sake, sir, because whether we are going to use volume control or pressure control, our target for driving pressure is going to be 12 to 15. Would it be okay, like if we start out with pressure control as a standard itself, sir? I mean, I'm just thinking out aloud because at the end of the day, we are going to target 12 centimeters of driving pressure. So would that be helpful, like for a newcomer, if you say, okay, just start with 12 centimeters driving pressure and 12 to 14 breath rate, look at the EtCO2 and then reduce it if need be.
I will take that question.
Yeah.
I personally, what I do, pediatric, obviously, I go for a pressure control ventilation. Adult, I set a tidal volume of around 6 to 7 ml per kilo. Start with a PEEP of around 5. And then I start my ventilation and I look for the pressures which are being generated. And my concept is keep your driving pressure below 15. And if the surgery is long, go for a recruitment maneuvers in between and maintain that PEEP. Obviously, the PEEP you have to individualize the PEEP depending upon the patient. It's not that I will use only 4 or 5 centimeter of PEEP. There are some patients who might require around 8 to 10 centimeter of PEEP. Ultimately, you have to see what is the maximum pressure which you are generating and accordingly increase your PEEP or decrease your PEEP to keep your driving pressure within 15 centimeter of water.
You hit it on the spot, sir. When you said patient-specific setting or patient-specific PEEP or what we would call as individualized setting for a particular patient. Thank you so much, sir. I think from the passionate discussion which everybody is having, lung protective ventilation should ideally be optimally followed by everyone. And if somebody is adept at using the automated recruitment, well, sone pe suhaga, as they say. Anyway, let us change over to low flow anesthesia and let's have a poll question during that time. Popped up there, and if I'm not mistaken, just hang on. They need to get adjusted to technology. Yeah. The lung protective ventilation. The earlier question was, does ventilation needs to be adjusted while on high or low flow? And the second question was...
Unmute your audio, I think, Imran.
Yeah, I think it's unmuted.
Yeah, we can hear you.
Yeah. I think most of them are getting it right. When there is if there is an impact on oxygenation, uh, what do we need to adjust? Do we still keep on the 30-70 oxygen nitrous oxide, whether we are on high flow or low flow, or should we change to 40-60, or should we look at the ETO2 and readjust the FiO2 to meet the patient's need, especially while on low flow? Because the concept was earlier was when you are using high flow, 30-70 was good enough, but you need the question. I think that's a discussion. You can take forward the discussion on that. I don't need to take away the thunder. Is the poll okay? I think we are getting a good response on the ETO2 part. You really need to look at the ETO2 and adjust the FiO2. That does happens to be the right answer. So let's begin this discussion on the low flow part. Okay, Dr. Shah and Dr. Roy, what is your experience on adoption of low flow anesthesia, sir? As we generally understand the low flow part, low flow ventilation.
By adoption by whom? By us or by
of course, you belong to the clinical fraternity. So the clinical fraternity adoption on your experience on low flow and your the fraternity's experience with low flow, sir.
So low flow is a very important consideration now with this or environmental problems. So it is definitely a big concern, and everyone should be change over to a low flow anesthesia whenever it is feasible. Now why people are not choosing low flow? The reason is that majority of them don't know how much is low flow. They'll switch over, they'll change from 6 to 4 liter, and they feel that they are actually delivering low flow anesthesia. So how much is low flow is the first problem which we are facing. That is why we are not getting good adoption. Second is, when they apply low flow, say probably they've gone to 1 liter and they feel that I am delivering 50% of FiO2 from my flow meter, but my inspired oxygen monitor is actually an end-tidal oxygen monitoring is showing wrong. It is going below. They have not understood the concept that FiO2 will keep on reducing if you are actually using low flow. So they feel FiO2 is dropping and there is some problem with my monitor. The third problem which we have seen, since we are taking these low flow workshops also, the third problem which we are seeing is that they have not understood the concept of MAC and depth of anesthesia. So they'll feel that I have set the dial concentration at 3%, but end-tidal concentration and the inspired concentration both are showing much lesser than what it is. So how much is low? What I'm setting is actually not reflected is the one major reason people are not comfortable with low flow. They are not sure and they are not comfortable because the figures which they are seeing is actually on the lower side. So to take that to that level, that they have to understand the low flow basically, and what happens with the low flow is major reason why people are not adapted to the low flow, and they are not sure also, am I giving adequate? How to monitor for gas volume deficiency is something which they have not understood. So they are not sure whether it is actually adequate or not. So these are the concerns from the other, the anesthesiologist side, why they are not adapting it to the low flow so easily and so quickly.
Thanks, sir. Shall I take it from west to east, Dr. Roy? Your views on the low flow part, sir, and what would you actually consider as low flow? What level of flow would be considered as low flow?
I personally, my experience with low flow is obviously it is one of the part of the lung protection ventilation. You are giving warm humidified gas to the patient, so it is one of the part of the lung protective ventilation strategy. And for me, low flow, I usually work on a flow of around 0.5 liters. I don't usually go for a metabolic ventilation. I work on 0.5 liters per minute. And regarding the adoption, obviously, if you have got high-end machines, the machine which you launched today, or any machine in which you have got ETO2 monitoring available, then only you should go for a low flow anesthesia. Without that, obviously, you cannot do a low flow anesthesia.
Obviously.
And but same as lung protective ventilation, even many of the anesthetists, they have got high-end machine with all the gadgets, all the monitors attached in their machine, but still their flow will remain around 4 liters, 5 liters, because to be very frank, this lung protective ventilation, this low flow anesthesia concept, it is not being taught at many centers in medical college during your PG days. If I don't know, Dr. Shah and Dr. Vakamudi will agree with me, this teaching of low flow and lung protective ventilation is still not happening at the post-graduation level. So that culture is not coming up.
I agree, sir. Low flow is mostly, like a personal choice. Like I am comfortable with it, so I will use it, as long as, of course, the patient is safe. So I fully agree with your views on that. Fully agree with that. Dr. Vakamudi, one question. When we are using either high flow or low flow, does a mode of ventilation, would there be a specific change in the mode of ventilation which we would like when we would like to shift over from a high flow to low flow and probably close to metabolic also?
Actually, no, it's not been shown that it may make a lot of difference between the types of modes of ventilation, as long as you actually monitor the
Deliver
parameters.
safe.
That's the most important point, as already Dr. Roy and Shah has actually talked about. It's extremely important that you need to monitor the patient's conditions in terms of the parameters, especially precisely the ETO. That's very crucial on the MAC. These are the two important things that you need to be very, very crucially monitoring right through. The other important point is, if you are actually also need to plan your anesthetic, and which not that every surgery is actually good for a local anesthesia. Again, true definition of local I'm talking about is probably not fit. Like for example, in cardiac surgery, there might be some instances where we may have to probably, I'm talking about true low flow. We're not talking about say 2 liters and 1.5 liters of flow, but true low flow again. Reason being, there are some times at which we may have to probably, disconnect and drop ventilations. Sometime. But having said that, it's important for us to understand that the types of ventilation, the mode of ventilation doesn't really matter. You can either use pressure support or volume control in the local anesthesia. It doesn't really matter in terms of the outcome, as long as you monitor the appropriate parameters and take care.
As long as you deliver.
Just to continue to answer what Dr. Roy was talking about, the teaching, and then that's one of the reasons why the current generation of anesthesiologists are all actually not looking or not getting acquainted with the low flow. I think it's very right. A lot of times there are operating rooms that are probably not prepped up enough to take care of the local anesthesia, or even if you have the gadgets around, but you probably not have the adequately trained anesthesiology teachers to actually who are being trained with local anesthesia to actually continue the training to the residents again. That's one of the things. But I think it's very happy to know a lot of workshops are being currently conducted on the local anesthesia, but it's still a long way ahead, in my opinion. I don't see too many operating rooms and too many anesthesiologists using true local anesthesia by definition.
Very true, sir. Very true. There's a lot left to be achieved so far in that space.
Not
But
just in India, it's across the world.
across.
The world.
We have machines. Yeah, we have machines which can do 300 ml flows also. But we have very few people who would love to work at that 300 ml fresh gas flows. I know most of you people routinely work on it. So just a generic comment which I made, sir, because
I
not many people work on low flows.
I don't work on 300
Okay.
ml.
Yeah.
So
Okay.
basically, the reason behind that in medical college and institute, what I have seen, actually we made in between, we made sort of few of us who were using low flow goal that every medical college in Gujarat should go down to 1 liter flow by say 2020. That was our goal. We have not achieved that so far, but our idea was that to take them to that 1 liter level. At least if they come down to 1 liter, there is a significant difference. So we were conducting workshops, and we have realized that they are probably in medical college. They are really afraid that going down will create problem. They are afraid of something. They don't know what it is. When we ask what is the problem, why, they're not sure. They cannot answer what are but they are really afraid, and they are not sure that the postgraduate around, we don't want to compromise the patient. I said there is no point. In fact, if you go for 1 liter and if you are giving 50% oxygen out of that, either air or a nitrous oxide, there are very minimum chances of FiO2 going below 30%. In majority set of patients, except a very obese patient whose oxygen consumption is very high, and that probably patient very, very rarely would go down below 30%. Otherwise, if you are giving 50% of oxygen to a patient with 1 liter flow, you have a very less chances of going to FiO2 below 30%, which is our upper safety limit. So these are the concerns which they are not sure, and still they're somehow not able to come out of that shell.
Yeah, because it's been followed, we'll just follow the same thing. It's time to, lay new path. Yes, sir.
One other point, to add to continue to what Dr. Shah is talking about. This also very often you find that a lot of anesthesia machines across in most of the hospitals and medical colleges also have lots of leaks.
Yeah, I agree.
Okay,
sir.
that's something which is a very
machine.
important point to consider before actually confidently putting up across. And you do accept leaks across, and I see this in most of the operating rooms. In excess, you override the system, even if you're talking about the workstations, you override the system and get on with your case, because otherwise your operating room is not going to be functional for that day. So people take chances, and I mean, this is practically it happens. We always know that, and it is probably right in their own way that it's good that they're not using low flow and a leaking anesthesia machine. It will be a disaster otherwise. One of the things that I'm just trying to put in another side of the story to across. Sometimes it do happen.
I agree to that, sir. That's why we started the discussion with the attributes of a machine. And once your machine is good enough, and you have adequate monitoring, like you have oxygen, FI and ET agent, because we are talking of only oxygenation, but there's another aspect where the patient needs adequate amount of agent also. So if you're having that, then I think people should go in for low flow with a level of confidence. I think we are at a time check level. This has been a very interesting discussion. Dr. Mehta, have you, had any concern when using metabolic flow, or any concern when using the newer robotic kind of surgeries in your institute, sir? Because we all along we have been talking of a person on a normal plane, but with the advent of robotic surgery where the patient is normally taken to a greater level of changes out there, would there be an impact on ventilation and gas delivery during that part of time, sir, during those surgeries?
Dr. Mehta sir is probably not there.
Okay. Maybe someone else can take it on his behalf. Just one routine question.
So that is with the metabolic flow. You said that you
any surgery, because one aspect was
No, as long as you are monitoring inspired oxygen concentration, which is not going below your desired limit, then if you have agent monitor, which suggests that your end-tidal oxygen concentration is appropriate as per your need for the consideration of the MAC or twice MAC awake, whatever concept you are following. So there is no need to go for higher flow. If you are able to achieve these two things primarily, and if your ventilation, there is no gas volume deficiency, that is a third thing, that there is no gas volume deficiency. Once you have achieved these three things, I think you should be okay with that. Absolutely fine. Any surgery. I don't know. I can have opinion from the other panelists, but I think we can go down to low flow if you have all these things for any surgery.
I agree with what Dr. Shah is telling. Once you have achieved your MAC, your ETO2 level, your everything you have achieved, your ETCO2 level, then what you have to monitor further, you can go down your flow to around 0.35, what you call a metabolic flow, and you have to just monitor the ETO2. You don't want your ETO2 to go below 30. I usually don't go below 0.5 because I do my maximum surgeries under supraglottic devices. So obviously there is some amount of leak around the supraglottic airways. So 0.35 will be quite a too low flow for me to work. So I usually don't go below 0.5. But I agree, you can always work for 0.35 once we have achieved everything.
No, patient outcome is good. Everything is good. We are good to go. Thank you for such an exciting session, sir. I think we have overshot our time limit probably. If anybody has any queries and all, we will definitely send it across to you to get a clarification for them basically. And I will hand it over to my colleague Emilia to propose a vote of thanks, sir. I really personally thank you, but in the scheme of things, from the company's point of view, she has to thank you, sir.
Good evening to you all. I'm Emilia De Mello, Product Manager for Anesthesia with Viproji Healthcare. We had an enriching experience with our panelists, Dr. Yatin Mehta, Dr. Vakamudi, Dr. Amit Shah, and Dr. Ritesh. And I thank them for their valuable time in sharing the views and insights on the safety aspects of anesthesia, especially in low flow, and the importance of using lung protective ventilation along with recruitment maneuvers in anesthesia. Just setting PEEP is not enough, but recruiting the lung first and then setting PEEP is really important. And this helps to reduce episodes of post-operative pulmonary complications. Coming to the concluding part of this launch, I take this opportunity to thank all our loyal customers who use GE anesthesia equipment and for making Viproji Healthcare the #1 anesthesia company in India.